Okay. Good evening and good afternoon in the United States. Welcome to the panel, during which we will confront one of the most important questions that societies all around the world face today. The question is, where are we heading in terms of epidemics? My name is Ignacy Morawski. I'm the chief economist of Puls Biznesu, which is the Polish business daily. And today we have a distinguished guest who will help us navigate among different issues related to the epidemics. That is Professor Martin Kulldorff, professor of medicine at Harvard University, a biostatistician and epidemiologist with expertise in detecting and monitoring infectious disease outbreaks and vaccine safety evaluations. Good afternoon, Professor.
Good afternoon, good evening. Great pleasure to talk to you.
Thank you. I should add that Professor Martin Kulldorff is one of the authors of the Barrington Declaration. This is the declaration signed by various scientists, which says that the strategy dealing with the epidemics that is based on lockdowns is fundamentally wrong, and that governments should choose another paths of dealing with the disease outbreak. Today's discussion will start with a short introduction by Professor Kulldorff, and then we will proceed to a Q&A session during which I will try to answer questions related to the pandemics and strategies of dealing with the pandemics, and talk with Professor Kulldorff about his thoughts about where we, as societies in general, where the world is heading. So please, Professor, the floor is yours, and we're happy to have you here.
Thank you so much. It's a great privilege. So when we look at public health, there are three basic principles of public health that we have ignored when this pandemic came, and that was basically thrown out the window in most places. One is that when we look at public health, we cannot just look short-term, we have to look long-term. Another one is that we can't focus just on one disease, like COVID-19. We have to look at public health in general, all diseases, all aspects of health. And also we have to really take care of everybody in the population, not just certain groups, but they consider the situation for everybody, including the working class and the poor. So that has been a problem, because what we have essentially been doing with the lockdowns is we have protecting low-risk college students and low-risk young professionals like lawyers or journalists or scientists like myself, who are low-risk and who doesn't need a protection, while we have been not protecting properly older and other high-risk groups, including older working-class people who might be working as a bus driver or a janitor or in a supermarket. So what we did in the Great Barrington Declaration, which I authored together with the world's premier infectious disease epidemiologist, which is Dr. Suneta Gupta at Oxford University in England, as well as with Professor of Medicine Jay Bhattacharya at Stanford University here in the United States, and which has been co-signed by thousands of other scientists, public health officials, and medical practitioners. So the basic of this declaration is that COVID-19 is very age-specific. So anybody can get infected, and all ages do get infected. But the risk for mortality is very different from the old and the young. And it's not just a 2-fold or a 10-fold difference. It's not even a 100-fold difference. It's more than a 1,000-fold difference in mortality risk between the oldest and the youngest. So for old people, COVID-19 is a very serious disease and more dangerous than the annual influenza. On the other hand, for children, it's a very mild, mostly asymptomatic or mildly symptomatic disease that's much less dangerous than the annual influenza. So the traditional way we dealt with pandemic, and which is included in the pandemic preparedness plans that most Western countries had prepared, years past, we urge countries to use focus protection, where we do a much better job protecting elderly and other high-risk groups in nursing homes, but not only, also those who live alone, as well as those in their 60s who are still in the workforce. At the same time, the collateral damage from the lockdown is enormous. Childhood immunization rates are down, have plummeted. Cardiovascular disease outcomes are worse. We are detecting fewer cancers, but that's not because there's less cancers, because we're not detecting them. And then somebody, because they didn't do the cancer screening, like a pap smear, for example, they may now die of cervical cancer in 3 to 4 years instead of otherwise living another 20 years. There's also have been enormous problems with mental health. So there are all these collateral damage that's caused by the lockdowns. So this is where we cannot just view one single disease, COVID-19. We have to look at it more broadly on public health in general, and not only short-term this year or this month, but also long-term, looking at the consequences in years to come. And the consequences of the lockdown, that's something we're going to have to live with, as well as die with, in many, many years in the future. So that's why we, in the Great Barrington Declaration, is urging that there would be better protection for older people who are at high risk, while we should minimize the collateral damage by letting children go to school, university students go to university for in-person instruction, and allowing young adults to go to work and to live their lives as normally as possible.
Okay. So shall we proceed to questions?
Yeah, I think that's sort of my short introduction.
Okay, thank you very much. I think it's really up to point in terms of the situation that we are in today in Poland and in Europe. In Poland, we've had a discussion, hectic discussion over the last couple of days, whether we should introduce the hard lockdown. Some of the members of the government are lobbying for this option, others are against. So we are just at the moment of the discussion about what you said, whether the pros or the advantages or disadvantages of hard lockdown are larger. But let me start with a question about non-lockdown strategy. I think that over the summer, many people in Europe were convinced that another lockdown is impossible for reasons that you mentioned, that the long-term costs are high. So European countries took the approach that more or less you advocate. We let the children go to schools, young people to university, people went back to work. The life seemed to come back to normal. But anyway, we did not manage to stop the epidemics. And now hospitals are full in Europe, in Poland and in other countries. And to me, it seems that lockdown became not a matter of choice, but necessity. When hospitals are full, what countries can do? Don't you think that this is like we are not in a situation of having a free choice? We are pressed to the wall.
So it's important to make sure that the hospitals are not overburdened, because that means that those who do get sick cannot get the proper health care. So that is important. And I understand that in the spring, there were certain efforts to flatten the curve. We can't prevent the disease from going. So what we did in the spring was flatten the curve, and I think most countries did that successfully. But what was also done was trying to suppress it. And because of that, that's why we now see it again. So what we did in the spring wasn't to eliminate it, we were just pushing the problem into the future. So that's an example where we shouldn't look short term, but we have to look long term. So what's going on now? We do need to keep the numbers in the hospitals down, but it's mainly older people who need hospital care, because if younger people get infected, they are either asymptomatic or typically mildly symptomatic, and very few of them end up in the hospitals. So it's mainly the older people who do end up in the hospitals, and of course also to end up with mortality. So the key to keep those numbers down is to do better protection of older people. So in nursing homes, that's the most high risk because not only are they old, but they are frail also. So in nursing home and other similar care settings, we have to do a lot better job protecting these high-risk residents. And the reason they get infected is from the staff who brings it in. So we need to do better testing of nursing home staff. We should also try to use staff, if as much as possible, for people who already have COVID so that they are immune and they can't pass it on to others. Visitors, it's important for residents to have visitors from family and friends, but it's important that we test them before they come for a visit. And if they're positive, they should wait a few weeks with their visit. We also have to do less staff rotation so that the same staff person so each resident see as few staff persons as possible, because that minimizes the risk of infection. Mm-hmm. And of course, there also has to be hygiene measures of washing hands and using proper personal protection equipment, etc. So we can do a lot better in the nursing homes than we're doing now, and we have to do that to keep both mortality down, but also to keep the hospital census down. Now, that's not enough, because we also have older people who live at home. And for example, we should help them so that they can receive their groceries delivered rather than having to go to the supermarket. They obviously need to meet family and friends, but the best thing to do that is outdoors. And if they can't do it outdoors, it has to be indoors. It's important that the family and friends get tested before visiting or before seeing each other. And they should avoid crowded places. It's good to go outside for exercise, but maybe you should not have your 82-year-old grandmother join you at the pub. That's not such a good idea. So they should stay away from those things until the time of high transmission is over. Also, people who are in their 60s are high risk, and they are working age. So if they can, they should work at home. If they cannot do that, I think as a society, we can help them to take 3 or 4 months sabbatical. That would be a lot cheaper than the cost of lockdowns, but to help them take this short-term sabbatical during major transmission so that they do not have to expose themselves while working as a bus driver or a janitor, etc.
But I think that there was a very hot debate between you and other people who signed the Great Barrington Declaration on one hand, and other epidemiologists who disagreed on the other hand. And people who disagreed with your position usually said that it's impossible to protect older people effectively, that you cannot build effectively a wall between age groups in the society. So they said that in theory it's a nice and elegant proposition, but in practice it will not work. And it seemed to me that the autumn in Europe demonstrates that to some extent those critics of Great Barrington Declaration were right. That no society in Europe managed to protect older people and prevent the disease from overwhelming hospital system. So I wonder, what is the key disagreement between you and other epidemiologists? Is it only a matter of effectiveness of protecting people, or or there are other important points of where you disagree?
So I think what's happening now in Europe and other countries is actually proof that the prior strategy of lockdowns did not work, because that was done in the spring and now it's coming back with a vengeance. So I think that is the ultimate proof that the strategy used during the spring and summer was not a good strategy, because we now have a problem again. We were just pushing things into the future. Mm-hmm. Now, in terms of protecting the elderly, I have heard that argument that it's not possible, but I've never heard arguments actually against the specific proposals that we are suggesting. Very few countries have actually implemented, no country has implemented all of these, and very few countries have even implemented a majority of them. So it's not, you can't just say it can't be done, but without trying. So certainly a lot of things can be done. Now the question is, can you protect every old person 100%? That's not possible in a pandemic. In a pandemic, there will be people dying, and those who try to get down to zero COVID, they're doing a huge disservice, because they're actually creating more. By trying to suppress it to zero, you're actually causing more mortality than you're preventing. So I think that's a very dangerous approach. So, and actually, we have been able to generate different risks in different populations, because if you look at least in North America, you can see that those areas or cities were more affluent. So we have protected the professional class who can work from home, but we haven't protected the older working class people who have been forced to work. So we have actually proved, and there's hard data from North America that shows that before the lockdowns in the spring, mortality and cases were about the same across the city. But then when you instituted the lockdown, it went down in the affluent areas with a lot of professionals who can work from home, while it skyrocketed in less affluent areas where the working class people live who could not work from home. So we have certainly proved that it's possible to distinguish and lower the risk for working class, for professional people, even the young ones who are at low risk, while it has been high for the working class. So it is possible to separate like that. It is not 100% possible, because there are some professionals who still have the disease. So it's not possible to do it 100%, but if we can do it even 80-20, that is going to reduce mortality a lot by protecting those older people. So and it's sort of a little bit hypocritical of members of the professional class, like scientists, to sort of say who benefited from the distinguishing between the high risk and the low risk, and putting high risk people at higher risk of the disease, to then say that it's not possible to do it any other way, which it is. So we certainly can protect the older much better than we are doing by these things I gave examples of here, and there are more examples in the FAQ, the frequently asked questions on the website of the Great Barrington Declaration. There are additional examples of that. And whatever strategy you do with the rest of society, I don't think there's any valid argument of not trying to implement all of these things that we are proposing for protecting the older and other high-risk groups as much as possible. And it's not being done right now, unfortunately. Instead, the focus is on closing schools or universities, or preventing young people from doing their activities. And it has been an utter failure with these lockdowns, and we see that proof of that now, because it's raging back.
Well, there are countries in Europe like Poland or Italy where there are a lot of older people living at home with their children and grandchildren. I think that this setup is much more difficult than in United States to control the epidemics. Don't you think that this is also a matter of the structure of society and households?
Yeah, so there are multi-generational households in the US also. And actually, the lockdown has made that much worse, because what's happened is that because of the economic hardships, many young adults have moved home back with their parents. And when they closed universities, the students went to live with their older parents. So the lockdown has actually created more multi-generational homes that wasn't there before. So that creates a problem. And you're right that there was a study from Stockholm, for example, where they showed that if you're above 70 and if you live with an adult that's working age adults below 65, then you're at about 60% higher risk of COVID than if you live with somebody who is your own age above 65, who is retired. So there's certainly a higher risk for older people if they live with the working age adults, like, for example, a son or a daughter. Now, living with children actually does not increase the risk anymore. So the children are not dangerous here. So they can still go to school fine. And we know that while adults can infect children, it's very unusual that children infect adults. So sort of almost for most part, it's a one-way street there. There are cases where children have infected adults, but it's rare. So what we then need to do with the multi-generation home is that if you do live like that, then even if they are less than 60 and they can work from home, they should do that so that they protect their older parents who live with them. If that's not possible, then maybe these older people can temporarily, for 3 or 4 months, during the height of transmission, maybe they can live with an older sibling or a friend for a while to have company, but also to isolate together. And if that's not possible, we could, if we wanted to, we could offer them some of the many empty hotel rooms that we currently have, where they can, if they wanted to do so, they can be more protected during the 3 or 4 months of the height of the pandemic. But this also goes into another problem with the lockdowns, because if you're old, it's not trivial to protect yourself. It takes both effort, but you can't, even if you try the hardest you cannot protect yourself for an indefinite amount of time. So the longer you postpone the pandemic, the harder it is to protect the elderly and for them to protect themselves. So if we do a focused protection, the pandemic will be over in 3 to 4 months, at most 6. And it would have been, if we used focused protection from the start, the pandemic would have been over by now in most parts of the world. So by doing these lockdowns, we're actually making it much harder to protect the elderly, because we have to do it for a longer time period, and that makes it much, much harder.
So I understand that we all know these charts with epidemic curves, and now in Europe, we are on top of a very large wave of infections. And there are various strategies. For example, some countries like Ireland or Czech Republic or Austria recently introduced very hard lockdowns. So there are stay-at-home orders, and non-essential shops are closed. And there are other countries like Poland, which aim at sort of limiting the spread of epidemics, but not suppressing it 100%. So what you say, I understand that you view the second strategy as more efficient, so that we should not suppress the curve to zero. Just let it burn through the society. Do I understand well?
Yeah, so actually I don't think either of those two things are good, because if we try to suppress it to zero, then once we open up again, it's going to be back. And that's what we have seen, because we did that in many countries in the spring, and we got a little bit of respite during the summer because it's a seasonal disease, but then now in the fall it's coming back. So that's a very short-sighted strategy to use. But also, we shouldn't let it just rip through society. That's a stupid thing to do. And nobody should try to get infected purposely. But we should try to minimize the collateral damage that we have. So, for example, young people, they should wash their hands. If they're sick, they should stay at home, and so on. So those kind of measures should be taken by everybody to sort of limit the infection. But the major focus should be on protecting the old, high-risk people, while schools, for example, are very, very, I think Austria is closing the schools now. I think Ireland actually kept them open, which I'm very happy about. They closed down pretty much everything else in society, but the schools were still open. And by closing schools, we're putting an enormous burden on children who are at almost no risk of this disease in terms of mortality or from it, and much less than the annual influenza. So, and if you want to know about school closings, we should look at Sweden, which was the only major European country that kept schools open during the spring during the pandemic. I think Iceland also kept them maybe open, but it's a very small country, so the numbers are very small. So in Sweden, schools were open from age 1, daycare, to age 15. And in this age group, there were 1.8 million kids in Sweden. And of these 1.8 million kids, exactly 0 died from COVID-19. So they are not at risk. And there were a few who were hospitalized, who needed to go to the hospital, but very few. And if we look at teachers also, they had the same risk as the average of other professions. So the teachers are not at higher risk because they work with children or are being exposed to children. So I think that was a very sensible thing to do. And schools are really important for children, not just for the education, but for physical health and mental health and social well-being. And Sweden did this by they avoided large school-wide gatherings of like 300 kids in the cafeteria at the same time. So they stayed in the classrooms, and if some kid was sick, they were asked to stay home, but they didn't wear any masks. They didn't do any social distancing. They didn't do any testing of children. So it was a very normal experience for the Swedish children throughout the spring. And I think they were very lucky to have that. So, and there's no public health reason to close the schools.
And epidemiologists in Poland often argue that it is school opening that caused the very large wave in the autumn nowadays. They argue that it's that the schools are the source of the spread of epidemics. So children go to school, they are infected over there, they remain asymptomatic, but they go home where they live with their parents and, what's worse, grandparents very often, and they infect them. This is the argument today in Poland, and that's why schools were closed. So what would be your counter argument? Are you really sure that schools are safe for the society?
Yes, so that's actually wrong, scientifically wrong. It's true for influenza. For influenza, schools, children are major transmitters and vectors of the disease. But COVID-19 is very different, so it's wrong. And we can see that because from the Swedish data where they were open. So if you want to think of it scientifically, we have to think, and if you want to know if something caused health problems, we have to look at those who were exposed. If you want to know whether smoking causes health problems, we have to look at the smokers, those who actually do smoke. If you want to look at what is the effect of vaccines, we have to look at the people who get the vaccines. If you want to look at the effect of a drug, we have to study the people who actually are taking the drug. So in this case, if we want to know what is the effect of school being open during a major pandemic, we have to look at Sweden, which was the country who actually kept the schools open during the whole height of the pandemic during the spring. And as I said, no children died during this time. And in terms of the teachers, they were not at higher risk than other professions. So if children were actually a major spreader, a major vector of the disease of COVID-19, then you would have seen higher infection rates and higher mortality among the children, among teachers compared to other professions.
Mhm.
Also, when they did the study in Stockholm, they found that older people, with typically a grandparent, but any older person who live with children, they're higher risk if they live with working age adults, but they're not at higher risk if they also, in addition to that, live with children. So there's very clear evidence that children are not the major spreader of COVID-19. There was also a very important study from Iceland where they looked at the genetics of the virus. And by doing that, they can see actually who infected who. And they found that there were a fair amount of infection from adults to children, but very few infections from children to adults. So that's another evidence that the children are not major spreaders here. So all those studies together makes it very clear that from a public health perspective, there is no benefit in terms of COVID-19 to close schools for in-person teaching. At the same time, we know that schools are very, very, very important for children, for their education, for their physical health, mental health, and social well-being. And I'm very, very concerned about the future of these kids who are not getting a proper education now for over half a year in some places.
So if you look at Europe and you have, like, for example, Ireland on one hand, which closed almost everything but kept schools open, and Poland on the other hand, which closed schools but let shops and important facilities work, which of those opposing models is better?
If there was only one thing that I could change, and that would be to make sure the schools are open. If I could only change one thing in any country, in the United States, for example, or in Poland or in Austria or other places, is that all the children can go back to school for in-person teaching. To me, that is the single most important thing. And the collateral damage is enormous by not having the schools open, while the benefits in terms of the pandemic is minuscule.
And is there a country that you think could be a role model for other countries as a manager as a good manager of epidemics? We all look to Korea or Taiwan, but they, on the other hand, seem very distant in cultural ways. So I wonder, what's your view on that? Which countries are role models for us?
So Japan is a country that has not done lockdowns, and mortality is very low in Japan. At the same time, we know from seroprevalence studies that there's been quite a lot of infections in Japan. The percentage of people with antibodies are quite high. So there's something with Japan that the disease there is spreading within the population, but they have very low mortality. So the question is, why is that so in Japan? Because they didn't do the lockdowns or anything like that. So one explanation is, I think Japanese people tend to live very healthy lives, and they have one of the longest life expectancies in the world. But I don't think that can explain all of it. But obviously, it's good to generally be healthy and exercise and eat healthy. That's always, if you haven't done that before, during this pandemic, that's a good time to start, because we know that diabetes and obesity are risk factors for COVID mortality. So there's something else also in Japan, and I'm not sure what it is. I don't think anybody knows what it is right now. It could be cross-immunity from other viruses in the past. It could be something genetic, but or combination of several things. But we don't know why Japan has done so well in terms of mortality, despite having a lot of infections and no lockdowns. And maybe Taiwan and South Korea has a similar situation as whatever is helping Japan might be helping them as well. But we don't know that quite yet. Eventually, I think we will find out. But as of yet, we don't fully understand the difference there.
There is an idea spread, especially among economists, and advocated, for example, by Paul Romer, the Nobel Prize winner in economics, which says that we should do mass testing, like test almost everyone in society once a week or once 2 weeks, with antigen tests. How do you view this proposal? It seems very radical and costly, but on the other hand, I think that maybe we have only radical solutions.
So we need to do much more testing to protect older people. So, for example, in a nursing home, when there's a lot of transmission in the community, I think we should test the staff every day or every other day. And we also have to do much better testing visitors to nursing homes and to older people in other settings. So that's an area where we have to do more testing, and we have to make sure that we get the results quickly, because it doesn't matter if you test nursing home staff and then find out a week later that they were positive, then the damage is already done. So those are settings where we do need more testing, more frequent testing, and more rapid testing. But to test asymptomatic people in society, like college students or children in schools or people at a regular workplace, that's more damaging than beneficial. One problem is that with any medical test, there's always false positives. Now, if you test somebody in the hospital who is sick, that's not a major issue. If you test nursing home staff, that's sort of okay, because it's better to be safe than sorry in that situation. But even if you only have 1% of the tests that are false positive, if you do mass testing of asymptomatic people, then you're going to have a lot of false positives, and then you may be going to prevent them or their family members or other contacts to participate in society and quarantine them or close schools, which is happening in the US. And that has major negative consequences on both them and the society, with no public health benefits. So to do mass testing of asymptomatic people is not a good idea.
But maybe you can detect the sources of epidemics faster and sort of suppress them.
So for some infectious diseases, that's true. So for example, when you had Ebola in the United States, there were a few cases, and it's important then to isolate the people with it and then do contact tracing to see who they were in contact with, and then test them, and then do further isolations maybe. So this is a strategy that's useful for some infectious diseases and very important. But it doesn't work for something like influenza or COVID-19, where there are so many people who are infected, and we don't even know the first person who brought COVID to Poland or to United Kingdom or to Italy or to Sweden or to United States. So in this situation, it's hopeless to do testing and contact tracing. It doesn't make any sense from a public health perspective. What we have to do is we have to protect the high-risk older people. And if younger people and children live their lives normally, then eventually we'll reach the immunity in the population that's necessary in order for the pandemic to end.
Mm-hmm. Okay, so I would like to spend the last couple of minutes talking about the future, what the future brings. What do you think is
difficult?
What?
That's difficult always. Predict the future.
Right, but what probability would you put on the hypothesis that within 1 year the pandemic, through the vaccine or some herd immunity or other technologies, will be almost over?
So as if for any pandemic, eventually it will end. That's for sure. We know that. Now, how long it takes depends on what strategy we use. And it also depends on the vaccines. So if we use the focused protection strategy, where we focus on protecting the elderly and other high-risk groups, then for sure this pandemic will end probably in 3 to 4 months, but at most 6 months. And by the next summer, the pandemic will be over. it will still exist within us, but in an endemic state, just like other coronaviruses that we currently live with in a natural endemic fashion. If we keep doing lockdowns, like for example Ireland, we are pushing this into the future. We are pushing the problem ahead of us. And if we do that, and if we don't get a good vaccine, then this could go on for years.
But has the information from Pfizer about the very effective vaccine changed your mind about what can we achieve with technology?
So we will hopefully have a good vaccine at some point, and hopefully sooner rather than later. That's part of focus protection. So that sort of goes very nicely in with the Great Barrington Declaration, in the sense that the vaccine will give us one more tool in our toolbox to protect the high-risk older people by, for example, vaccinating nursing home staff and family members of nursing home residents, so that they don't spread the disease to the residents, and also to vaccinate, of course, older people. But both of those are actually important, because it's unlikely for the vaccine to be 100% effective. And the effectiveness could actually vary by age also, and we don't know that yet. So hopefully we'll have a vaccine, and hopefully sooner rather than later. But it's obviously not an immediate solution for the next, for this winter season, because even if we have a vaccine that's approved in, let's say, December, which would be the most optimistic scenario, and even if it's very effective, it's going to take several months before we can vaccinate everybody that needs to be vaccinated.
Should the vaccine be mandatory for everyone, or only the vulnerable population, or should it be voluntary?
It's always best if vaccinations are voluntary.
Why?
I think that in public health, you have to have trust between public health scientists and officials and the population. And if you have to force people to do something, that means that the trust is not there. So but I would expect that if we get a good vaccine that's both has efficacy and safety, then I would expect most people who benefit from this vaccine will want to take it. I would be very surprised if that's not the case. But it could very well be that a vaccine is such that it is beneficial for certain groups, but not for other groups. That could very well be, but we don't know enough about the vaccines to determine what groups will benefit the most from whatever vaccines comes out there.
Mm-hmm. And do you think when you follow the news about vaccines, in what direction do you think they go? I mean, there was a very huge wave of optimism after the Pfizer announced that they have, that the effectiveness of the vaccine is 90%. Is it sort of close to your expectations, or were you positively surprised, or you're just observing from the distance and waiting for more confirmations?
So that's only from a press release by Pfizer. So they haven't released the actual data that it's based on. So but I think there's still many question marks. 90% effectiveness is great if that's true, but it's 90% effectiveness for infections. So does that mean that there's also 90% effectiveness for reducing mortality? That was not part of the press release, so we don't know what the numbers are for mortality, which is obviously also a very important metric to evaluate the vaccine. So there are still very many question marks. So I think we should be optimistic about a vaccine, but we don't necessarily know yet what and there are other vaccines other than Pfizer, which also seem to have some promise. So we will just have to hope for the best, and eventually we'll find the numbers and see the data to determine who should be vaccinated, where it makes more sense, where it will make the biggest difference.
Okay, Professor, I must admit that I feel sort of sad at the end of our meeting because it was so interesting that I would like to continue for another hour or 40 minutes, but unfortunately we are just in time. So thank you very much for your time, and we appreciate your contribution to our discussion in Poland about epidemics. And I follow you on Twitter, and I recommend everyone else to follow you on Twitter and your discussions with other epidemiologists. So thank you very much again, and hopefully we will meet again in the future, maybe during Freedom Games or other event during more peaceful times.
Thank you so much. It was a great pleasure talking to you, and I really like that you are asking the hard questions because that's what we have to do during a pandemic like that. We have to have these very frank discussions. So I really appreciate that. And also appreciate all your listeners who were listening to this. So thank you. And,
thank you.
Also, I'm a native of Sweden, so I consider you close neighbors and friends in Poland.
Yes, exactly. Okay, so thank you very much. And I wish you a good rest of the weekend.
Thank you.
Thank you. Yeah. Goodbye.